Have you ever thought about how, a simple cough, maybe a bit of fever, can actually turn into something really quite serious, especially when it gets down into your lungs? Well, today we're going to do a deep dive into exactly that. We're talking about community-acquired pneumonia, CAP, specifically when it's bad enough that someone needs to be in the hospital. Yeah, and for this deep dive, we're drawing on a really thorough, evidence-based clinical review from UpToDate. So think of this as getting an expert-level view on how doctors actually diagnose and treat this without you needing the medical degree. Our mission today is really to give you a kind of shortcut to understanding the pretty complex decisions and the key factors involved when managing hospitalized CAP. We'll pull out some surprising facts, some key insights, but try to keep the heavy medical jargon to a minimum. We're really exploring the whole journey from arrival to heading home. Okay, so let's unpack this. Community-acquired pneumonia, CAP. What exactly is that? Basically, it means a lung infection, an acute one, that you get outside of a healthcare setting, like out in the community. Okay. And that's really different from pneumonia someone might get after they're already in the hospital for something else. That's hospital-acquired pneumonia, or HAP.
That distinction is fundamental.
And here's something interesting from the source material. This term you might have heard, healthcare-associated pneumonia, or HCAP. It's actually not used anymore.
Yeah, that's a relatively recent shift, but an important one.
Why did they drop it? Apparently, it was often just too broad. It led to doctors maybe using stronger, more wide-ranging antibiotics than were really necessary, kind of overkill sometimes.
Exactly. Overly sensitive is the term often used.
So now, those patients who might have fallen under HCAP, they're generally managed more like standard CAP patients, though doctors obviously still look closely for specific risk factors for those drug-resistant bugs before deciding on treatment.
And that whole process is so critical because CAP, well, it's not just a chest cold. It's common, yes, but it can be incredibly serious. It causes significant illness, morbidity, and unfortunately mortality too, especially if you're looking at older adults or people with other health problems.
Right, which explains why figuring out the right approach right from the start is so vital.
Absolutely foundational.
So picture this. A patient comes into the hospital. Doctors suspect CAP. What's the very first major decision they have to make?
It's about the site of care. Basically, where does this patient need to be? Can they go home? Do they need observation, maybe a regular medical floor bed? Or are they sick enough to need the ICU, the intensive care unit?
And how do they make that call?
The single most critical factor is simply how sick the patient is, the severity of the illness. To help make that objective, clinicians often use prediction rules, scoring systems, the Pneumonia Severity Index, or PSI. That's the one that's really strongly preferred.
Why that one?
Well, it's shown to be the most accurate, and importantly, its safety and effectiveness in guiding that site of care decision have been, actually confirmed by studies.
Okay.
There's another one, the CURB-65 score. It's simpler, easier to calculate quickly, perhaps, but its track record for guiding treatment locations safely hasn't been empirically assessed in the same way.
So they plug in the numbers and that's it.
Oh, no, not at all. And this is crucial. Clinical judgment should always be used. These scores are tools, really valuable tools to help the assessment, but they don't replace a doctor's experience and overall assessment of the patient. They're just one piece of the puzzle.
Gotcha. Okay, so the patient is admitted, maybe to a ward, maybe the ICU. Now, here's where it gets really interesting, I think. Doctors have to figure out the likely culprits, right? The germs causing the problem. But isn't it true that a lot of the time, they never actually pinpoint the exact bug?
That's absolutely correct. In a significant number of CCAP cases, the specific organism is never identified. So doctors have to make educated guesses based on probabilities, the usual suspects, as you call them.
So who are these usual suspects? Does it depend on how sick the patient is?
It does, yes. For patients who are admitted to a general medical ward, the most common culprits are bacteria like Streptococcus pneumonia, that's pneumococcus, and then various respiratory viruses.
Like the flu.
Exactly. Influenza, parainfluenza, RSV, rhinovirus, and obviously during the pandemic years, SARS-CoV-2 was a huge cause of CAP. Less frequently, you might see things like mycoplasma, Haemophilus influenza, or Legionella.
Okay, so that's the general ward. What about the ICU? Are the germs different there?
The distribution shifts, yes. Pneumococcus is still number one, very common even in severe cases. But in the ICU, you're more likely to encounter Legionella, certain gram-negative bacteria, and Staphylococcus aureus.
Staphylococcus, right?
And specifically, there's a concern about community-associated MRSA, that's methicillin-resistant Staph aureus. CA-MRSA can cause a really nasty necrotizing pneumonia, tearing up lung tissue, and it comes with high morbidity and mortality. So the stakes are higher in the ICU, and the potential pathogens reflect that.
That makes sense. So you mentioned MRSA, and I know Pseudomonas is another one doctors worry about, these sort of tougher drug-resistant bugs. What specific clues, what risk factors make a doctor think, uh-oh, maybe we're dealing with one of these? Because that changes everything treatment-wise, right?
Yeah, absolutely changes the initial antibiotic choice. You need specific coverage. So for Pseudomonas and other resistant gram-negatives, the really strong risk factors are things like, does the patient have a known history of being colonized or infected with Pseudomonas before?
Okay, so past history is huge.
Huge. Also, recent hospitalization, particularly if they received IV antibiotics within the last, say, 3 months, that's another major flag.
Any others for Pseudomonas?
Yes. If a good quality sputum gram stain actually shows gram-negative rods, that warrants empiric treatment. Other factors include any recent antibiotic use, even oral recent hospitalization generally, having a weakened immune system, certain underlying lung diseases like cystic fibrosis or severe COPD needing frequent steroids or antibiotics, maybe suspected aspiration. Even having multiple other medical problems like diabetes or alcoholism can increase the risk.
Wow, quite a list.
There's actually a large study, multinational, looking at this. Pseudomonas caused about 4% of CLK cases, and the big independent risks were prior Pseudomonas history that increased the odds like 16-fold, having a tracheostomy, bronchiectasis, needing breathing support or vasopressors, and very severe COPD.
Okay, so that's Pseudomonas. What about MRSA? What raises the suspicion there?
Similar logic. Again, the strongest risk factor is known MRSA colonization or a past MRSA infection. That's number one.
Makes sense.
Also, if the sputum gram stain shows gram-positive Kochian clusters, that's characteristic of staph, that's a strong indicator. Other things include, again, recent antibiotic use, especially IV within 3 months, recent hospitalization, end-stage kidney disease.
Kidney disease. Interesting.
Yes. Also, things like participating in contact sports, injection drug use, living in crowded conditions, being incarcerated, men who have sex with men, having a recent flu-like illness, or if the pneumonia itself looks particularly bad on imaging, like it's necrotizing or has cavities, or if there's empyema, which is pus collection around the lung.
So a lot overlaps with Pseudomonas risk, but some unique factors too.
Definitely. And then there's drug-resistant Streptococcus pneumonia, DRSP. Risk factors there lean towards things like age over 65, using certain antibiotics, beta-lactams, macrolides, fluoroquinolones within the last 3 to 6 months, alcoholism, other medical issues, immunosuppression, or exposure to a child in daycare. If someone's recently had one type of antibiotic, doctors will generally try to pick one from a different class.
Okay, so doctors are constantly weighing these risks to decide if they need to go beyond the standard treatment. It's like detective work.
It really is.
So let's say they have a suspicion, or even if they don't suspect resistant bugs yet.
Yeah.
How quickly do they need to get tests done and, more importantly, get those first doses of antibiotics into the patient? It feels like a race against time.
It often feels that way, and acting quickly is paramount. For diagnostic tests in the hospital, there's a whole battery of things they might do: general blood work, imaging, of course. And then specific tests looking for particular bugs if the history suggests it, like maybe travel history for certain infections or exposure history.
Or getting samples before antibiotics.
Yes, ideally, things like sputum for gram stain and culture and blood cultures should be collected before the first antibiotic dose. That gives the best chance of identifying the organism. But, and this is absolutely critical, starting antibiotic treatment should never be delayed just to get those specimens if it's proving difficult or time-consuming. Getting the antibiotics in quickly is the priority, especially if the patient is very sick.
Okay, that makes sense. Don't let perfect be the enemy of good, basically.
Exactly. Oh, and another test often used now is procalcitonin. It's a blood marker related to bacterial infection. They often check it at diagnosis and then maybe every couple of days. It doesn't usually decide which antibiotic to use, but it can be really helpful later on in guiding how long the treatment needs to continue.
Interesting. So the timing of that first antibiotic dose, how fast are we talking?
For patients admitted to a general medical ward, the general consensus and guideline recommendation is to start antibiotic therapy as soon as CAP is considered the likely diagnosis, and ideally within 4 hours of presentation.
4 hours. And if they're critically ill.
If the patient has septic shock, which is a severe, life-threatening response to infection, then antibiotics should be started within 1 hour. Every minute counts there.
Wow, 1 hour.
Now, there's been some academic debate about whether that early administration is independently linked to survival, or if it's just that sicker patients who get delayed treatment do worse anyway. But practically speaking, nobody doubts that delaying antibiotics for seriously ill patients can have really bad consequences. There was a large Medicare study, for instance, showing that getting antibiotics within 4 hours was associated with slightly lower mortality and about half a day shorter hospital stay. It points towards urgency.
That's pretty clear evidence. So given all this, the severity, the potential bugs, the timing pressure, how do doctors make that initial antibiotic choice? What goes into that decision for, say, a patient on the general ward versus someone in the ICU?
Right. So it usually starts empirically, meaning based on the most likely pathogens before any specific lab results are back. And most hospitalized patients, especially initially, get IV antibiotics.
Why?
Primarily because CAP can be fatal, and if someone is quite ill, you can't be sure their gut is absorbing oral medications properly. IV guarantees delivery. Later, as they improve, they can often switch to pills.
Okay, so standard patient, medical ward, no big red flags for MRSA or Pseudomonas. What's the usual approach?
The suggested approach, and what's very commonly done, is combination therapy. Typically, an anti-pneumococcal beta-lactam antibiotic examples are ceftriaxone, cefotaxime, ampicillin, sulbactam, given EV, plus a macrolide antibiotic like azithromycin or clarithromycin, which can often be given IV or orally.
A beta-lactam plus a macrolide. Why the combo?
It covers the most likely bacterial culprits, including pneumococcus and the atypical bacteria like Mycoplasma or Legionella that macrolides are good at treating. Doxycycline is sometimes an alternative to the macrolide.
Is there an alternative to that combo?
Yes. Monotherapy, just one drug with a respiratory fluoroquinolone, like levofloxacin or moxifloxacin, is an option maybe for patients who can't take the beta-lactam macrolide combo for some reason.
But you said the combo is preferred.
Generally, yes. Many observational studies suggest patients, especially those with severe CAP, might do better with the beta-lactam plus macrolide combination. One theory is that macrolides have these immunomodulatory effects. They might help calm down the body's inflammatory response, which can be helpful. Plus, there are concerns about fluoroquinolones regarding side effects, like C. difficile infection risk and promoting resistance. So combo is often favored.
Okay. Now, what if they do suspect MRSA or Pseudomonas on the ward?
Then the coverage has to be expanded immediately. You add agents specifically targeting those suspected pathogens right from the start. The exact regimen depends on the specific suspicion, but it would be broader than the standard combo.
Got it. What about in the ICU? If someone's that sick but still no initial suspicion of MRSA or Pseudomonas?
It's still combination IV therapy. Usually a potent anti-pneumococcal beta-lactam, similar options as before, maybe drugs like ceftaroline or ertapenemone too, plus typically an advanced macrolide like IV azithromycin. A respiratory fluoroquinolone could be used as the second agent instead of the macrolide. But again, macrolide-containing regimens are often favored in severe CAP, potentially for those immune benefits.
Okay. ICU with suspicion for Pseudomonas.
Right. Now you need empiric therapy that hits pneumococcus, Legionella, and Pseudomonas. So you're looking at combination therapy with a strong anti-pseudomonal beta-lactam, think piperacillin tazobactam, cefepime, meropenem, plus an anti-pseudomonal fluoroquinolone like ciprofloxacin or levofloxacin.
That sounds like heavy-duty stuff.
It is, but crucial if Pseudomonas is a real possibility. Importantly, if subsequent cultures come back and don't show Pseudomonas, then that specific anti-pseudomonal coverage should be stopped, narrowed down.
Makes sense. Don't use the big guns longer than needed. What about ICU with MRSA suspicion?
Empiric treatment needs to include an agent active against MRSA. The main choices are IV vancomycin or IV linezolid.
Vancomycin or linezolid? Any preference?
It depends. Linezolid might be preferred if community-associated MRSA is strongly suspected, maybe in a younger person with that necrotizing pneumonia picture, because linezolid is thought to be better at inhibiting the toxins MRSA produces. Also, there's growing concern about some MRSA strains becoming less susceptible to vancomycin, what we call MI-SCREEP, and in those cases, linezolid is often preferred.
Okay, and you mentioned that nasal swab test.
Yes, the rapid nasal PCR for MRSA, if available, it's really helpful. If that test is negative in a patient who's getting better, you can often confidently stop the empiric vancomycin or linezolid. It helps avoid unnecessary exposure to these powerful drugs, high negative predictive value.
Good tool to have. Any cautions with those drugs?
One specific caution, Combining vancomycin with piperacillin tazobactam, which might happen if you're covering for both MRSA and Pseudomonas, has been linked to an increased risk of acute kidney injury. So clinicians need to be aware of that potential interaction.
That's a lot to track. What if someone has a penicillin allergy? That must complicate things.
It definitely does. The choice depends entirely on the type of reaction they had. A mild rash. They might still tolerate certain related antibiotics like cephalosporins, but a severe reaction like hives, swelling, anaphylaxis, or a serious delayed reaction like Stevens-Johnson syndrome. Then beta-lactams, cephalosporins, and carbapenems are generally out for empiric therapy.
So what do they use then?
Alternatives might include combinations like a respiratory fluoroquinolone plus aztreonam, or if you need Pseudomonas coverage, maybe levofloxacin plus an aminoglycoside. It requires careful selection based on the allergy history and coverage needs.
Wow, the complexity is just incredible, tailored down to the specific allergy.
Has to be.
So beyond the antibiotics themselves, what's truly fascinating, I think, is this idea of adjunctive therapies, things given in addition to antibiotics. What's happening there?
That's a really important area of research and practice. Glucocorticoids or steroids are probably the main adjunctive therapy discussed for CAP.
Steroids. Why would you give steroids for an infection?
It seems counterintuitive, right? But the rationale is to dampen the body's own inflammatory response to the infection. Sometimes that inflammation can cause more damage to the lungs than the microbes themselves, leading to things like ARDS, acute respiratory distress syndrome, or worsening respiratory failure.
So it's about controlling the collateral damage.
Precisely. The idea is that reducing inflammation might reduce progression to severe lung injury and potentially improve survival.
Does it work? Who benefits most?
The evidence suggests the greatest benefit seems to be for patients who are already in respiratory failure or needing mechanical ventilation, either invasive or non-invasive, or those with significant hypoxemia needing a lot of oxygen support. And crucially, it seems to work best when given early.
So what's the recommendation?
For most immunocompetent patients meeting those criteria, severe CIP with respiratory failure or significant hypoxemia guidelines suggest considering a continuous infusion of hydrocortisone, usually 200 milligrams daily, for about 4 to 7 days, followed by a taper. Early initiation, ideally within 20 hours of ICU admission for severe CIP, seems key.
Is there strong evidence for that?
Yes, a key multi-center randomized trial looked at about 800 ICU patients with severe CAP. Those who received hydrocortisone within 20 hours had a 5.6% absolute reduction in mortality at 28 days compared to placebo. That's quite significant.
But are there downsides? Risks?
Definitely. Steroids aren't benign. They can impair the immune response against certain pathogens, so they're generally avoided if the CAP is thought to be caused by influenza, tuberculosis, or fungi, or if the patient has other active viral issues like hepatitis or herpes. For immunocompromised patients, it's a very careful case-by-case decision. And they aren't routinely used for less severe CAP unless there's another reason, like an asthma exacerbation.
What about side effects?
Hyperglycemia, high blood sugar, is very common and needs management. Most trials haven't detected a major increase in serious adverse events, but they often excluded high-risk patients. One trial did show a higher rate of GI bleeding, though still low overall, and some observational data suggest even short-term steroid use might increase risks like fractures or blood clots down the line, so it's a balance.
A real balancing act. Okay, shifting gears a bit. Let's talk about the road to recovery. Once the right treatment is started, how quickly do patients start feeling better? And how long does the whole treatment usually last? It sounds like it varies a lot.
It absolutely varies, and managing expectations for the patient is so important. With appropriate antibiotics, you typically see some clinical improvement. Maybe the fever starts coming down, breathing gets a little easier within 48 to 72 hours.
2 to 3 days.
Right. But things like fever, especially with the significant pneumonia, might take 3 days or even longer to fully resolve. There was one trial where the median time to achieve overall clinical stability, defined by normal temperature, heart rate, breathing rate, blood pressure, and oxygen levels, was 4 days.
Okay, 4 days to stability. But feeling totally back to normal takes longer.
Much longer.
Yeah.
This is key. The time it takes for all symptoms to disappear and for the chest X-ray changes to resolve is considerably more prolonged. For instance, a cough might linger for 8 days on average, maybe longer. Those crackling sounds in the lungs might take 3 weeks to clear up.
3 weeks just for the lungs to sound clear?
Yes. And perhaps the most striking statistic is that up to 87%, almost 9 out of 10 inpatients treated for CAP, still report having at least one pneumonia-related symptom, like fatigue, cough, shortness of breath, maybe chest discomfort, a full 30 days after they were initially diagnosed.
A whole month later, still feeling it.
Yes. So telling patients this upfront helps them set realistic expectations. Recovery can be slow. It's not like flipping a switch.
What of the x-ray? Does that clear up quickly once they feel better?
Typically, no. The radiographic improvement almost always lags behind how the patient feels clinically. In one trial of severe CAP, after 7 days, 56% felt clinically better, but only 25% had resolution on their chest x-ray. Even at 28 days, when 78% were considered clinically cured, only about half had radiographic resolution.
Oh, that's a big lag.
It is. And how quickly the x-ray clears depends on factors like how much lung was involved initially, the patient's age, and whether they have underlying lung disease. Younger folks with no lung problems might clear in 4 weeks, but older individuals or those with conditions like COPD might take 12 weeks or even longer.
Do they need follow-up x-rays then?
Usually not if the patient has clinically recovered fully after treatment. The follow-up visit is more about checking on symptoms, and importantly, it's a good time to review their risk factors for lung cancer, age, smoking history, given they've just had a chest x-ray, even if it was for the pneumonia.
Okay. You mentioned earlier that if they identify the specific bug, they can narrow the antibiotics.
Yes, that's called de-escalation. Once reliable tests confirm the pathogen, therapy should be narrowed to target just that organism. This avoids unnecessary broad-spectrum antibiotic use, reducing side effects and resistance pressure. Studies show this pathogen-directed approach gives similar cure rates, but with fewer adverse events compared to just continuing broad empiric therapy.
And the MRSA nasal swab helps with that?
Yeah, exactly. Several studies support de-escalating empiric MRSA coverage, stopping the vancomycin or linezolid if that nasal PCR test is negative. It has a very high negative predictive value, meaning a negative test makes MRSA pneumonia highly unlikely, allowing safe discontinuation of those drugs.
Good to know. And the switch from IV to pills, when can that happen?
Patients who needed hospitalization usually start on IV. They can typically be switched to oral therapy when they are clearly improving clinically, they're hemodynamically stable, good blood pressure, heart rate, they're able to take medications by mouth, and their gastrointestinal tract is functioning normally.
Do they have to wait a certain number of days?
Not necessarily. Studies actually support an early switch strategy. Doing it as soon as those criteria are met is safe and effective, and it's been shown to reduce the length of the hospital stay, sometimes by almost 2 days on average.
And do they need to stay in the hospital overnight just to see how they do on the pills?
No, that's generally not considered necessary anymore. If they meet the criteria for switching and are otherwise stable for discharge, observing them overnight just for the switch isn't required.
Okay, so minimum 5 days of treatment total. Is that the rule?
That's the general guideline for uncomplicated CAP, where the patient has shown a good clinical response within the first few days, a minimum of 5 days total therapy.
But there are conditions before stopping at 5 days.
Yes. Before stopping, the patient should be a febrile no fever for at least 48 to 72 hours. They should be breathing okay without supplemental oxygen, unless they needed it chronically before, and they should have no more than one sign of clinical instability, like heart rate still over 100, breathing rate over 24, or systolic blood pressure 90 or less. If they meet all those criteria, then the stopping after 5 to 7 days is usually appropriate.
And that procalcitonin marker can help.
It can help guide the stopping decision, yes. If levels are low and the patient is clinically stable, it provides more confidence that it's safe to stop antibiotics, often supporting those shorter 5 to 7 day durations.
Are there times when treatment definitely needs to be longer than 5 or 7 days?
Oh, absolutely. Longer durations, often 7 days or more, sometimes much more, are necessary in several situations, even if the patient seems stable and procalcitonin is low. For instance, if the initial empiric antibiotics didn't actually cover the bug that was eventually identified, or if the infection spread outside the lungs like meningitis or endocarditis, pneumonia caused by certain difficult pathogens like Pseudomonas or some unusual organisms often requires longer courses, and complications like necrotizing pneumonia, lung abscess, or empyema also necessitate longer treatment.
What about MRSA pneumonia? How long for that?
For MRSA pneumonia without spread elsewhere, if the patient responds well within 72 hours, treatment is generally around 7 days. But if MRSA got into the bloodstream, bacteremia, then a minimum of 2 weeks is needed, and often longer, potentially 4 weeks or more, if there are metastatic complications or the patient is immunocompromised.
It sounds like despite the evidence for shorter courses, people might often get treated for longer.
That does happen. Data suggests patients are often treated longer than guidelines recommend, maybe a median of 8 days with potentially 2 excess days. Importantly, studies show these longer courses weren't linked to better treatment success, but they were associated with more patient-reported side effects, mainly diarrhea and rash, about a 5% increase for each extra day of antibiotics. So there's a real push to stick to the shortest effective duration.
Right, avoid unnecessary treatment. Can antibiotics ever be stopped really early?
Yes, if it turns out the initial diagnosis was wrong, maybe the patient actually had heart failure presenting like pneumonia or pulmonary embolism. Or if it's confidently diagnosed as viral CAP, the patient's improving, a virus is found, no bacteria identified, and maybe procalcitonin is low, then antibiotics can often be discontinued early as they aren't helping.
Okay, and finally, discharge. When can someone go home?
Discharge is appropriate once the patient is clinically stable from the pneumonia itself. They can reliably take oral medications. They don't have any other active medical problems meeting hospital care. And importantly, they have a safe environment to go home to for continued recovery. And as we said, no need to keep them just for observation after the IV to oral switch. Follow-up is key, usually within a week or so, and then maybe later to ensure full resolution.
That recovery phase is just as complex as the initial treatment, it seems.
It really is a continuum of care.
Looking ahead now, if we connect this to the bigger picture, are there new treatments or new antibiotics coming down the pipeline for CAP?
Yes, there are some newer antimicrobial agents that have gained FDA approval for CAP. Drugs like omadacycline, which is related to tetracyclines, delafloxacin, an extended-spectrum fluoroquinolone, and lefamulin, which is from a class called plyromutilins.
Are these game changers?
Well, they offer additional options, which is always good. They have activity against typical CAP bugs, and some cover atypicals and even MRSA, though generally not Pseudomonas. However, because they're newer, there's less real-world clinical experience with them, especially in patients with very severe CAC or infections caused by really virulent pathogens like MRSA. So for now, their use is often reserved for situations where the standard older options can't be used, maybe due to allergies, significant drug interactions, or known resistance. They're valuable additions to the toolkit, but not typically first line for most hospitalized patients yet.
Good to know things are still developing.
Yeah.
Now let's flip to prevention. What can people actually do to try and avoid getting CAP in the first place, or at least avoid serious complications?
Prevention is hugely important. Top of the list is vaccination.
Flu shot and...
Yes, annual influenza vaccination for basically everyone without a contraindication, and pneumococcal vaccination. This is indicated for all adults aged 65 and older, and also for younger adults and children who have specific risk factors, things like chronic heart, lung, or liver disease, diabetes, weakened immune systems, cochlear implants, CSF leaks, or problems with their spleen. Getting vaccinated against flu and pneumococcus significantly reduces the risk of getting pneumonia from those specific pathogens.
What else besides vaccines?
Smoking cessation is absolutely critical. If a patient with CAP smokes, quitting should be strongly encouraged and supported both during the hospitalization and at follow-up visits. Smoking damages the lungs' natural defenses.
Makes sense. Anything else?
One thing that's particularly relevant for hospitalized patients, especially older adults, is preventing falls and functional decline. Getting patients mobilized early and often during their hospital stay as tolerated is really important. It helps maintain strength and reduces the risk of complications like blood clots or further weakness, which aids overall recovery.
Right, keeping people moving. Okay, so we've covered a massive amount of ground here. What does this all really mean for us? We've walked through this incredibly intricate process diagnosis, figuring out the bugs, tailored treatment, recovery. It just highlights how dynamic and, frankly, complex managing hospitalized CAP is.
It truly is dynamic and complex. And I think while all the details might seem overwhelming, the core message is that every single patient's experience with CAP is unique. It demands really careful, individualized attention from the medical team. It's this constant balancing act, needing to act quickly and decisively, but also needing to be precise, using evidence-based strategies, choosing the right drugs for the right duration, and always trying to minimize potential harm from the treatments themselves.
That sums it up perfectly, a real balancing act. So here's a final thought for you, our listeners. Consider how understanding this detailed, evidence-driven approach to what is, after all, a common but serious illness like CAP, how that understanding can actually empower you. Maybe it's for advocating for your own health or for a family member, or maybe it's just gaining a deeper appreciation for the incredibly complex decision-making that goes into modern medical care every single day. It really is quite something.